It is my pleasure to introduce today Dr. Kavita Arora, who is Associate Professor of Reproductive Biology and Bioethics, as well as the Durkar Biscotti Endowed Professor of Women's Health and Wellness at Case Western Reserve University. She is a practicing general obstetrician gynecologist at Metro Health Medical Center, where she serves as the department's Director of Quality. Dr. Arora received her BS with a minor in philosophy from Penn State University. In 2009, she graduated with both an MD from Jefferson and a Master's of Bioethics from the University of Pennsylvania, where I got to know her. She completed her residency in OBGYN at McGraw Medical Center of Northwestern in 2013 and completed a Master's in Science of Clinical Research at Case Western in 2019. She currently serves on the Governing Council for the Young Physicians section of the American Medical Association. She serves as a vice chair of the National Ethics Committee of the American College of Obstetricians and Gynecologists, and she has served on the National Ethics Committee of the AMA as well. Her research interests include reproductive ethics, disparities surrounding postpartum contraception and sterilization, patient-centered quality of care, uterus transplant, and ethics education. She's also going to be giving OBGYN grand rounds tomorrow morning at 7:30 on the topic of sterilization. So if you're really interested in Dr. Arora's work, please join us for that as well. That can be reached via Blue Jeans. But please join me in welcoming Dr. Arora.
All right. Perfect. Thank you. So as Dr. Spector-Baghdadi said, I'm looking at understanding contraceptive choice today. Thank you so much for inviting me. Here are my disclosures. Everyone starts or ends their talk with acknowledgments. I like to start my talks with acknowledgments because literally nothing that follows would have been possible without these people, and especially for some amazing trainees on here who hopefully didn't get too much blood involved, but definitely sweat and lots of tears. So thanks for them for their help. These are the objectives of my talk today. So I want to review the factors that impact postpartum contraceptive choice, identify challenges in understanding and assessing patient choice, and then most importantly for this audience is extend the conversation to other areas of bioethical inquiry. So this isn't just an OBGYN talk. This is more about informed consent and how do we assess choice and what do patients want, how that goes into that. So I'll try to point out some areas where I think there's overlap in some other work, especially work that's being done here, and as well as broader conversations. And I hope that this ends up giving us all more questions than answers and starts a dialogue. All right. So just as background, using the framework of reproductive justice, I wanted to look at sort of the clinical and ethical goal for postpartum contraception. So first, we need to understand what the patient's goal is of postpartum contraception, then remove barriers to provision, right? That this is done in an equitable fashion, hence the justice part of reproductive justice, and then she has access to desired contraceptive method. So it's really the first part of this that I'm going to focus today on, so understanding what her desires are, and some of the barriers and access stuff I'll talk about more tomorrow for the OBGYN grand rounds. So as clinical background, before I keep talking about postpartum contraception, I wanted to sort of review what contraception methods there are. So this is from the CDC, this is just prevalence data. So the most commonly used contraceptive method in America is the birth control pill, closely followed by female sterilization, and then condoms and long-acting reversible contraception, which we'll talk about in just a second a little bit more, make up the next and sort of portion of this. In total, those represent about 75% of used methods, and some of the other short-acting methods round out the list. The CDC also gives us this helpful chart where they make everything sort of hierarchical based on efficacy. And so at the top is what's most effective, and at the bottom is what's least effective. So the least effective things are like fertility, awareness-based methods, or spermicides, and at the top are your sterilization, both male and female, as well as the long-acting reversible methods. These include things like the implant, which it goes in the arm under the skin, or the intrauterine devices. The short-acting methods like the pill, the patch, et cetera, are all sort of tier 2 methods because their efficacy is like 91 to 93-ish% versus 99% for the long-acting reversible and sterilization methods. So this is how the CDC encourages physicians and clinicians to counsel regarding contraception, right? So do this in a tier-based method, concentrate on the tier 1 methods for patients because they're the most effective, and then sort of quote unquote move down the list with the implication that going down is sort of less good than a tier 1 method, right? Sort of the name of that suggests that's the optimal method. Except that ignores how patients make decisions, right? So women don't make decisions about contraception solely on efficacy, and we have qualitative and quantitative data showing us this. Rather, they use a variety of factors. Efficacy is certainly an important factor. It's generally in the top 3 reasons, but it's not the sole reason. So other reasons women choose a specific contraceptive method may include mechanistic reasons, method effect reasons, social reasons, as well as practical reasons. So for example, in mechanistic reasons, ease of use, whether they have to remember to take a pill every day or just have something they can place and forget, how quickly they can return to fertility after the method is stopped. What's the invasiveness? Some people are okay with the procedure for birth control, others are not, and whether or not it uses hormones. For method effect, whether or not it protects against sexually transmitted infections, other side effects such as mood changes, weight gain, and then non-contraceptive benefits. So making periods lighter, mood effects, et cetera, could all be reasons that people choose one method over another. And then finally, there's the social aspect. So what are their expectations for contraception? What are their expectations for pregnancy and conceiving and how they want to conceptualize intendedness or planningness of pregnancy? What are their prior experiences with different contraceptive methods? Did they like it? Did they hate it? Religious considerations, and then family and partner considerations all go into this aspect as well. And then finally, the practical stuff. How much does it cost? Is it even available to them? So none of this is neatly summed up in this tier-based mechanism that we are supposed to be using as backed by the CDC and the WHO. But what data do we have to how we actually understand choice, right? So if it's not solely efficacy, what are other factors that impact choice? So these are some of the things that I made a list of that we do have some data about, but there's probably more that we don't or have limited data about. So that's sort of one of the other things that I would sort of reach out as not just in contraception is what are the factors that we have thought about and researched, and what are factors that we haven't even thought about or haven't even researched, right, that patients do use into decision making for contraception or any other thing. So let's start first with the demographics. So age parity, which is the number of pregnancies and children that you have, as well as race and ethnicity. So what do we know about this? So we know that contraception use increases by age. So the older you are as a woman, the more likely you are to use contraception in your reproductive years. And we also know that the type of method you use changes with age. So women, as you get older, are more likely to use sterilization as their method of contraception and less likely to use condoms and birth control pills or other short-acting methods. This sort of makes sense. What I want to focus on is, as far as hone in on for the informed consent, is this aspect. So this is 15 to 29-year-olds in sterilization. So not surprisingly, it's kind of low. What we would expect, right? Most 15-year-olds don't want their tubes tied. But the field has recently had a backlash about age restrictions and sterilization. So we see this in the popular media. So this is Self magazine, Child Free by Choice, when you don't want kids, but your doctor won't listen. This is Vice, the outrageous reasons these women couldn't get their tubes tied. And the byline says, people are being denied tubal ligations because they're too young, childless, only have one child, or aren't married, or any other reason that their doctor chooses. Or this one's my favorite, how doctors fail women who don't want children, right? And presumably doctors' hands saying no to them. I will point out that all but one of them are men. Only one looks like a female hand. But so this is what's in the popular culture, right? That we are saying no to women who want sterilization because of age. And what's the reason for that? So a lot of it stems from this one big study called the Crust Study. It was a multi-center national study. Hundreds of thousands of women were enrolled, and they looked at failure of various sterilization methods and then also risk of regret. And they showed that the cumulative probability of the risk of regret was about 13%. And when you broke it down by age, those who were sterilized younger than 30 years had almost a 3 to 4-fold increased risk of regret compared to those who were sterilized over 30, which is why a lot of clinicians who are OBGYNs will say, no, I will not sterilize you under the age of 30 because you have a high risk of regret, and I don't want to be a part of that, right? And in more recent meta-analyses, they've actually showed it's 2-fold increased risk by age. So maybe not a 3 or 4-fold, but in some, there's an increased risk of regret for sterilizations as women are younger. And this is also true based on time of when sterilization is performed. So there's an increased risk of regret if sterilization is performed closer to delivery, so the postpartum time period. And this is exactly why when clinically we urge doctors and hospitals to do sterilizations, because a lot of women lose their insurance postpartum, and so postpartum contraception is incredibly effective at preventing rapid interval subsequent pregnancies that are associated with high maternal and neonatal morbidity, right? So it's actually a public health measure is to increase postpartum contraception access rates. But we know that regret goes up if we sterilize women right after delivery compared to waiting after delivery. So how do you sort of balance this, right? I will note one of the criticisms of this is that they define regret as requesting information about sterilization reversal. And so that may not be women who are 100% interested in sterilization reversal, but most people don't go around asking about reversal if they haven't even thought about it a little, right? So it may not be the perfect way in a big multi-center study to define interest in reversal, but it is a decent way. Only 1% of these women actually obtain reversal, which lots of people point to in a lot of these popular culture articles as the risk of regret being actually lower and much lower than what clinicians use. Except I think that's sort of an oversimplification because sterilization reversal isn't covered by insurance, so it costs about 10 grand. And so asking people to actually pay for that is very different than people who want it but can't get it because of resource issues, right? But take it to me for informed consent, what do we do with this, right? So we are asking for people who have autonomy and should be able to go to their OBGYN and ask for surgery, and then you're faced as a clinician with the information that there is a 2 to 4-fold higher risk of regret if done for a 25-year-old, and especially if done right after delivery. One of the other criticisms in one of the study, and also one of the frequent responses by the OBGYN community, is now that we have great alternatives. We didn't at the time of the Crust Study. IUDs weren't as available. Nexplanons, the implants, weren't as available. And so now we have methods that are just as efficacious. So why don't we just give the woman an IUD? She won't get pregnant. And then when she's 5 years older and she's thought about it a little bit more, then we will sterilize them. But that's really not autonomy either, right? If she actually wants sterilization, a permanent procedure, and you're offering her something that isn't that, even if they're clinically the same efficacy level, it's not the same thing. So you really haven't fulfilled her autonomous choice. And so this is a conflict of sort of benevolent paternalism, right? Doctors aren't doing this maliciously. They think they're acting in the patient's best interest, but it's not really what she wants at that point, right? And so it's her and her own decision-making and what she wants now, or a future conception of herself who may or may not regret this procedure. So moving on, one of the other demographic factors is race. So we know that method use varies based on racial and ethnic groups. And breaking it down further, Black and Hispanic women are more likely to pick sterilization, whereas Caucasian women are more likely to use a partner's vasectomy in a relationship as their contraceptive method. Caucasian women are also more likely to use the birth control pill, while Depo-Provera, the shot, is more likely to be used by Black and Hispanic women, and condoms are more likely to be used by Black and Hispanic women too. So method choice differs between the races and ethnicities. But is this because different women of different races and ethnicities choose different methods because of their own cultural norms, family norms, their own personal desires, or is it a result of bias and racism? So, as background for sterilization, Unfortunately, we have a long history of reproductive coercion and contraceptive coercion in the United States, right? So we were sterilizing poor women and women of racial ethnic minorities against their wishes well up until the mid-1900s. And in fact, right, there's a famous Supreme Court case, Buck v. Bell, where Supreme Court Justice Holmes said 3 generations of imbeciles is enough, right, to say that we can sterilize African American women against their wishes. And this is what prompted the sterilization policy that Medicaid has that they put in place in 1976. So it took to 1976 for the government to say that this is not okay. And what the policy is puts in place a waiting period and a specific consent form that has to be signed before sterilization can occur in order to hopefully protect against these coercive practices. And it would be great to think that it no longer happens, but as recently as 2006, in the California penal system, 150 Latina women were forcibly sterilized against their will without informed consent. And just 2 years ago, a judge in Tennessee was offering female inmates 30 fewer days on their sentence if they were to get sterilized. So this is still a part of the fabric of this nation, that we value some women's reproduction less than others. And we also see it in supposedly well-meaning public health policies, right? So LARC, long-acting reversible contraception, has been heralded as a game changer for women's health. And in a lot of ways, it is. It's reduced our rate of hysterectomies because it can be used to treat heavy periods. It's a fantastic form of contraception for women who want it. But we've turned it into a public health quality measure. So there's LARC First initiatives where hospitals are being encouraged to offer LARC at the day of service. So if you come in for a postpartum visit, you come in for discharge, you come in for a mood check, whatever it is, we're supposed to be discussing LARC with you and offering it that day, which is fabulous from a removal of external barrier standpoint if the woman actually wants it. Not so great from a consent process or prevention of coercion process, right? There have even been states that have been talking about tying Medicaid funds to including LARC in their mental health clinics, right? So let's talk about how states conceptualize who should get pregnant and who shouldn't, and actually thinking about consent. LARC is a quality measure used for hospitals. So what percentage of your postpartum patients get LARC? And now there's initiatives for the last 5 years to do post-placental LARC, which is put in IUDs after delivery or implants before people go home. Again, amazing from a reducing of external barriers standpoint, and awesome if women want it, right? And if one of the things that was standing in the way of you wanting it is your worry about pain, and here you have an epidural and you won't feel it, and that's great. This is fabulous. But when we interview women who are getting post-placental LARCs, a fair number of them, almost 20% at some institutions, say they felt coerced into it because they came on a labor delivery, they were contracting, they were in pain, and somebody said, hey, do you want an IUD? We can just do it, it'll be super easy. And then they end up with an IUD, which is bad enough, but worse because the R of long-acting reversible contraception implies reversibility, right? And you have to have access to having it removed in order for it actually to be reversible. Otherwise, it's almost like sterilizing someone. And if you lose insurance and can't pay the fee to get it removed, it's not reversible. And there's such a focus on LARC for everyone in the clinical communities that doctors are hesitant to remove it. And they will often try to dissuade patients from getting it removed. So apart from sort of the racism, coercion, outright policies we also see sort of the more insidious implicit bias. So when you do interviews of low-income women and women of color, they're more likely to report discriminatory practices in contraceptive counseling than middle-class white women. So they say their doctor told them that they should limit childbearing, or gave them unbalanced information about various contraceptions, or tried to minimize the side effects. And they felt like they had this notion of who was able to be a good parent and who wasn't able to be a good parent from their doctor. And what ends up happening is that they end up saying yes to the method in the office, right? They don't want to upset you, they just want to get out of there. And then they end up stopping the method. And now you think they're on a method and they really aren't on a method, and so that leads to unintended pregnancy, but it also leads to distrust. and hesitancy to come back to the doctor and impedes future contraceptive use. So it's sort of a vicious cycle because then they have an unintended pregnancy and then the system judges them again, right? Saying you had an unintended pregnancy. When we look specifically at sterilization, in physician surveys, physicians know that they're more willing to sterilize older, postpartum, Paris, Black, or poor women. And this is data and that was from about 30 years ago. We repeated the survey 3 years ago. And age and parity are still big reasons people will decline to perform a sterilization in somebody who's requesting it or recommend a sterilization in somebody who's not requesting it. Race has sort of fallen off. But there's some survey bias there, right? And so who knows how much that plays into it. But some people were willing to admit that race factors into when they recommend it, even if patients aren't requesting sterilization. All right, so age, parity, race, and ethnicity, some of these demographic issues. And again, sort of bridging to other fields, I would want us all to think about how this factors into our own sort of counseling of patients and our own theoretical work in consent, right? So how do the factors of age impact our decision making, right? Like if we're thinking about pediatric surgeries and what people can assent to and how you factor in what future versions of yourself would want versus the current version, and factors that we think probably are a little bit more insidious, like bias. All right. Coming back to contraception, another factor that impacts decision-making is our life events, right? So if we're talking about postpartum contraception, there's that elephant in the room about pregnancy and delivery. And we don't like saying that pregnant women can't make decisions, right? We don't want to say that when you're in labor, you can't make decisions. That doesn't make any sense. You have full autonomy over your body. You can say yes to the things you want to say. You can say no to the things you don't want to say. And yet, maybe it changes your decision-making somehow. So 91% of women, when they were interviewed, noted that pregnancy and childbirth changed their contraceptive priorities. That makes sense. And 43% stated that the delivery specifically changed their preferred method of postpartum contraception, right? Whether they wanted something more effective because now they've got a screaming baby in their hands, or something less effective because they're like, this was kind of cute, let's do this again. Who knows? But it changes their postpartum contraceptive method. So we wanted to look at this further. So we looked at 3 years of our delivery data, so 8,600 patients, and mapped what postpartum contraceptive choice they wanted in antenatal care, during the delivery admission, right before hospital discharge with that cute baby, and at their postpartum visit. And just to give you background, our patient population is about 70% Medicaid, about 60% minority. We're an urban tertiary care county hospital, so we serve the underserved. And this was a retrospective chart review, so we couldn't ask people what their plan was, but we used notations in the chart as evidence of what their desire was. So with those limitations in mind, this is what we found. So the 1 is tier 1, 2 is tier 2, 3 is tier 3, 4 is none, and decline is sort of missing. And you see that the plans change. So there's an obvious joke about women and changing your mind in there, but we're going to get that and say that only 12.5% of people in our population had a consistent contraceptive plan from beginning of pregnancy to postpartum care. And those 12.5% did better in terms of outcomes, and they also were a different demographic group. So they had a higher parity, they had more kids, they had delivered via C-section, so most of those wanted their tubes tied and then had a C-section and had their tubes tied, right? So their plan didn't really change postpartum because it had already been performed. They also had adequate prenatal care, and they had private insurance. Those that were more likely to have a consistent plan ended up choosing more effective methods. They were more likely to get their plan. They achieved their plan less quickly, and that seems a little startling and sort of incongruent, but that's based on sort of external practice-based issues at our hospital at the time. So if you wanted a LARC method in 2015, when we were doing the study, we made you come back for a second appointment and didn't do it at that postpartum visit. So we artificially prolonged the time to getting your method. And so because most of these women were picking LARC or sterilization, which had to be scheduled after your postpartum visit, if not done at C-section, that's why the time is longer. They were less likely to return to postpartum care, and that's a subgroup that had already been sterilized during C-section, right, because they felt like now they didn't need it, and also less likely to have a subsequent pregnancy because they already had their contraceptive method. So assessing what choice you have is important because it impacts outcomes. And then back to the regret piece. We were curious about regret in our patient population. So we looked at people who wanted sterilization all through their pregnancy and then didn't get it. And of those, almost half of the privately insured women and a quarter of the women with Medicaid didn't receive sterilization because they had changed their mind. And we're like, well, did they really change their mind, or was it something else, right? Was the doctor saying, we're too busy to do it right now, you're gonna have to come back for another OR day, and now you have a kid, and you have to go back to work, and so you're like, well, just give me the IUD instead, right? And that was evidence in a chart review of changing your mind because you got a different method, right? Because we weren't actually interviewing people prospectively. So we're like, well, let's look at the C-section population. Here are women with an open abdomen with a surgeon who should be able to get their tubes tied if they want to get their tubes tied. And in that patient population, 9% of them didn't get their sterilization they had said they desired prenatally because they changed their mind by the time they were on the operating room table. So again, bridging out to other topics, how do we incorporate that into clinical decision-making in our research, right? Patients don't have static decisions that they make and then never change for years forward. And it's certainly not the case with big life events like delivery, deaths, childbirth, et cetera, hospitalization, sickness. And so shared decision-making is the easy answer, right? That's sort of our classic answer in ethics. But it really is a longitudinal process, and how you remove barriers and assess choice longitudinally is where I think the rubber meets the road. The next part of this is stuff where we have a lot less information for contraception. So marital status and the partner's input, familial input, and cultural input. So what we know about postpartum contraception is that women in more exclusive or longer relationships tend to be more likely to use longer-acting or hormonal methods of birth control rather than short-acting methods like condoms. They also note that their partners are much more engaged in the process of contraceptive discussion-making than women who have shorter relationships or less exclusive relationships. But even among married women, when you interview women about it, there's actually a fairly decent split of women who think contraception is a couple's job versus the woman's responsibility alone. And I totally acknowledge that this is very heteronormative, and I apologize for that. So not all married women will think of this as a relationship thing, and not all non-married women will think of this as solely their responsibility, right? So that's important to think about who else is inputting into this decision-making. Then there's all the familial inputs. So it's classically described for adolescent girls. That makes sense. Mom brings them to the pediatrician. Mom is inputting about what form of contraception she should use. But moms continue to have that input even as women get older, and they will note that their mom often plays a bigger role in their contraceptive decision-making than their partner. There is some impact of grandparents, dads, siblings, et cetera, but mom tends to be the biggest in surveys. And then patients also talk about distrust of physicians and distrust of methods, right? So when you have recalls of methods or methods taken off of the market or increased rates of infection with the older methods of IUD, that stays ingrained in sort of cultural discussion, and 20, 30 years later still plays into the fabric of contraceptive decision making. And so unless you assess what the inputs are into their decisions, it's hard to sort of circumvent those, overcome those. All right, and then finally, financial considerations. So this we do have a little bit more information about, and mainly from the Contraceptive Choice Project, which is probably the family planning study of the decade. And this is a large study in St. Louis done for several years in which no-cost contraception was provided in various clinics, and they prospectively followed over 9,000 women in the area to see what method choice changed with removing external barriers and standardizing contraceptive counseling. And they showed that choice for IUDs and implants went up when we removed cost as a barrier. Just as a frame of reference, if you were to buy the IUD, one of the IUDs and your insurance didn't cover it, it's about $400. The insertion fee is another $400, right? So this is a prohibitive thing, and the removal fee is about $300-400 as well. So going in it's expensive, going out it's expensive. So removing costs is a big deal. And that was shown not just in St. Louis, but also when we look across the country. Dr. Moniz here in Michigan showed it with the national inpatient sample up to 2012. Here's our data showing it carrying forward to 2016. So IUD use over time has gone up after the Affordable Care Act, where we removed barriers to contraception, right, as it's covered with no cost. And sterilization use is going down, presumably because people have alternatives that they want to use. All right, so now that we've sort of talked about some of the decision-making inputs and data that we do have about how women choose contraception, what are some ways that we can extend this conversation to other areas of bioethical inquiry? So when you're having an informed consent conversation with a patient or thinking about it in a research capacity, it's all about a partnership, right? A partnership between yourself and the patient. But is it just that patient, or is it also all of the other inputs that come into that conversation, whether it's her partner or her family, her social network, her cultural background, and how do you assess who that partnership is, who the patient wants in the room or in that conversation, so to speak, and who she doesn't? And what are the goals? It's easy as OBGYNs to assume that the goals are prevention of pregnancy, but maybe that's not the goal. And in fact, when we look across different races, we see that that conception is different, right? So women who are minorities think of unplanned pregnancies as less negative than women who are Caucasian, right? And so when you do studies and frame things as unplanned pregnancies are bad, that may not necessarily be true. And so assuming what the goals are sort of a non-starter for the conversation. And information retention and health literacy, right? This applies to so much of what we do clinically and also from a consent perspective. But that CDC chart is busy and it's hard to understand. And trying to give that as an infographic doesn't really absorb for most people. It's even hard for me to understand, right? So what does a 91% success rate mean? That sounds pretty good. Except you think that I'm going to see more than 100 patients in a week. That means 9 of them will have contraceptive failures within a year. That's actually kind of unsettling, right? And what that translates to the N of 1, whether she's that, for her, it's either 0 or 100%, right? And how you convey those statistics. And then similarly, how you present that risk. What is the risk of a pregnancy to her? And dealing with alternative information sources. So is your patient coming to you wanting surgery because she's heard about it on the internet? Or she has read about it in a popular culture magazine or from Gwyneth Paltrow as what she needs to do for her body? How do you express uncertainty? I don't know if I want your kid to have this surgery because I'm not sure about this. Or I don't know if you want sterilization because of that, right? So how do you deal with uncertainty in what a woman wants to do? I will often have people say, well, I'm leaning towards sterilization, but then I think, what if something happened to my kid? What would I want to do? And there's 2 easy paths. There's only sort of 2 answers I can say. Yes, I will do it, or no, I won't, right? And how you deal with a very uncertain future with very linear, concrete actions that have to be taken at that time. And then finally, how you deal with decisional regret. It's really easy to say that patients are allowed to make bad decisions. It's really easy to say that, right? That's what autonomy is. You have the ability to make great decisions, and you have the ability to sometimes make bad decisions. But it feels different when it's surgery. Right, because you are not just a technician for hire doing this, but it is also your moral autonomy who's going into whether you think this procedure is valid or this procedure isn't, and for this patient. And so how you deal with, as an individual surgeon or an individual clinician giving a prescription or an individual ethicist making a clinical ethics recommendation with the fact that what she currently wants may be different from what she later wants, and how you reconcile those two, and how much benevolent paternalism is okay and how much isn't. And I would venture to guess that's probably different depending on the field and the stakes of the decision being made. So as I mentioned, I wanted to leave time for dialogue about some of these issues, so I will wrap up and look forward to the conversation.